So to move on and discuss the exemplars that are part of psychosocial adaptations, we're going to start and talk about pathophysiology, etiology, and clinical manifestations of cerebral palsy. So when we are talking about cerebral palsy, the true definition is really a non-specific term applied to disorders that are characterized by early onset and impaired movement and posture. So, when you're thinking about cerebral palsy, most oftentimes we associate physical disabilities that we see occurring very early in childhood. It is the most common permanent physical disability that we see in childhood, and most oftentimes it's associated with a prenatal brain abnormality. 80% are caused by unknown brain abnormalities. Oftentimes, in the prenatal period, we see intrauterine exposure to infection, also known as chorioamnitis. A lot of the preterm infants or infants born prior to 36 weeks gestation have cerebral palsy, and that's simply due to the fragility of that newborn's brain. We also can see cerebral palsy as a result of shaken baby syndrome. So this talks about the new definition that your textbook gives, and you can see a photo, and this photo is also in your textbook, but we see it involving movement and postures. Oftentimes the child does have limitations, and it is a non-progressive disorder. So what disability that child has is what that child will have for the rest of their life. It typically is not going to get worse, especially if we're involving physical and occupational therapy. So when you are thinking about the different types of cerebral palsy, spastic cerebral palsy, dyskinetic, and ataxic are the three that we really see most often. With spastic, a lot of that is related to the jerky type movements that they have. They don't really have a slow, fluid gait. So when we see those types of things, oftentimes physical therapy, occupational therapy, getting aids and things like that to help them with those involuntary movements are going to be important. We also see a lot of drooling and speech problems. With ataxic cerebral palsy, that's where you see rapid, repetitive movements. The child has a wide gait, and oftentimes they are unable to hold onto objects. And with the mixed, there is a mixed or dystonic, which is just a combination of the spastic and the dyskinetic. With the dyskinetic, we see slow or worm-like movements of extremities. And so there's lots of different things that you need to think about when you are considering nursing care across the lifespan. Really the biggest thing is getting early diagnosis, intervention, and treatments for improved outcomes. So we want to discuss a little bit about diagnostic evaluation and then therapeutic management. So when you are thinking about diagnosis, the possible motor functions that we see earliest are going to be poor head control after the age of 3 months. We see stiff or rigid limbs, an arching of their back, or kind of almost, it seems like they're trying to push away from whoever is holding on to them. We can also go to the other end of that spectrum and have very floppy tone, the inability to sit without support by the age of 8 months. Some of the behavioral signs that you might see are excessive irritability. Maybe the infant isn't smiling by the age of 3 months. Feeding difficulties, which puts them at risk for aspiration. Persistent tongue thrusting, so pushing of the tongue forward. Frequent gagging or choking on whatever they're eating. So when you're looking for diagnosis, really early intervention by that assessment. So being in tune to where these children need to be as far as age development, physical abilities, those types of things. Neurologic examination with a detailed history. We can also look at neuroimaging, so your MRIs are going to be important, and then metabolic and genetic testing will also be part of that evaluation. So for goals of therapy, we want to establish locomotion, communication, and self-help. We would like to gain optimal appearance. We would like to correct associated defects as soon as possible. We'd like to see these kids getting integrated and provide educational opportunities that are adapted to that child's capabilities. And by mainstreaming, we will see an increase in socialization. So those are going to be the goals of therapy: establish locomotion, gain optimal appearance, correct associated deficits, provide educational opportunities, and promote socialization. So therapeutic management could include braces, orthopedic surgeries, pharmacologic agents. They do talk about Botox injection, or this botulinum A injections as Botox, which helps with some of the spasticity. So when you are thinking about those pharmacologic agents, think about your antispasmodics such as baclofen, Flexeril, those types of things. We want to assist the family in devising and modifying equipments, so involving occupational therapy, involving physical therapy, education on how to administer medications safely, thinking about safety precautions. So in the beginning of this unit, we talked about helmets and making sure that we keep our patients safe. So it could also be making sure that we protect their skin underneath braces, that we are being careful when we transfer them into wheelchairs. So thinking about safety precautions, involving them as part of recreational activities for therapeutic management so that they are involved. And then we also want to think about the support for the family. So how can we get this family some support? So question 1 is listed out here. And hopefully you chose the answer A. When we think about failure to thrive is another exemplar that we see oftentimes in our pediatric population. Just failure to grow, failure to gain weight, those types of things. So when we talk about failure to thrive, what we see with failure to thrive is that we see low growth markers. And so when you're looking at a growth chart and you're looking at the curvature of that chart, what we tend to see is that they sit low as far as height, weight, head circumference, and then sometimes we also will see some developmental delay. So falling underneath that 10th percentile for height as well as weight. When you think about organic failure to thrive, that is going to be medical. So it's some medical reason why this infant isn't gaining weight. So it could be that the child is on medication, the child is receiving chemotherapy, the child might have GERD, or they might have any type of medical reason that they're not gaining weight. The non-organic then is going to be a non-medical reason for failure to thrive. So with that non-organic, that's the possibility of parents not understanding how to mix formula correctly, and they're not feeding correct proportions, or they're not feeding their child, and the child isn't gaining weight. So we see what happens to these children with failure to thrive is that they eventually kind of fall off that growth curve. And so if they continually stay at that 5 to 10th percentile but show growth or show stability, then we don't really consider them failure to thrive. It's when they're falling off that 5 to 10th percentile on the growth chart. So therapies utilized, we're going to talk about some alternative feeding techniques and methods that might be utilized when you have a patient with failure to thrive. So you might consider gavage feedings. So with gavage feedings, it could be nasogastric or oral gastric. We also have the gastrostomy or jejunostomy, or feedings through their stomach. when you are thinking about those types of things, it can be intermittent or it can be a continuous feeding. And when you are working with these children with failure to thrive, oftentimes maybe mom and dad have some type of developmental delay as well, or they're not understanding what they need to do. So providing lots of education and getting them the information necessary to take care of these children, especially if we have to send them home with PEG tube feedings or NG or oral gastric tube feedings. So a few different ways. Also, other things, total parental nutrition, which would provide is an IV infusion, and with total parental nutrition, it does have to be given through a PICC line or a central line, and it's really a highly concentrated nutrient solution. So it's an IV solution that has a specific makeup for that child, and there is special lab work that needs to be done, nursing interventions, watching blood glucoses, watching lab values, things like that. As far as evidence-based nursing interventions for clients with failure to thrive, things that we need to think about are, you need to determine that underlying cause as always, and then once you have that underlying condition or underlying cause determined, then it's centering that care around that particular child and coming up with the best possible outcomes. As far as helping to improve absorption of feeds, if you have a child that's not gaining weight and they are being fed appropriately, what you can, try to do is teach parents, better techniques for feeding. So not propping the bottle, making sure that they have some type of interaction, that these feeding techniques are used consistently, maybe having a quiet or calm environment rather than having the TV turned on and the child's watching TV rather than eating, and mom and dad are eating and then really not paying attention to what that child's eating. So a few different things to think about when we are trying to have improved weight gains from proper feeding techniques. The last exemplar is Down syndrome, and this is the picture that is offered in your book. Down syndrome is also known as trisomy 21. With trisomy 21, it is an extra chromosome on chromosome 21, and we see that in 90% of the cases. It can be translocation of chromosomes 15 or 22, but most oftentimes it is 21. It is the most common chromosomal abnormality that we see in the United States, and it's up to 1 in 800 to 1,000 live births per year. So you can see that advanced maternal age does play a part in it, but we are seeing adolescent teens having babies, and their babies being more prone to having Down syndrome. So we kind of are seeing both ends of the spectrum there. It is the most common genetic cause of cognitive impairment, and it does occur more often in Caucasians than it does African Americans. So diagnostic evaluation, if you were just looking at the infant, these are things that you would probably see some different facial features, talks about their chest, genitalia. With the hands and feet, typically what you see is that there's an excess skin in the neck folds. There is a plantar crease between the big and second toe. We see a wide space between the big and second toe. Also, with looking at their face, we tend to see just the ears being low set, a depressed nasal bridge, protruding tongue. Oftentimes you'll just see one crease across the hand. So different things that you can look at when you are just looking at the child.